Welcome back. Tonight we have in-house Dr. Ahmad AlKhabaz. Dr. Ahmad, who is a consultant pediatrician in Mubarak Al-Kabir Hospital. He is allergist and immunologist, and he also has a specialty in bronchial asthma. Dr. Ahmad, thank you for joining us.
Thank you for inviting me.
Dr. Ahmad, we got you today because we have lots of questions about this field, and it's because of the children, and there are lots of issues around children, and as everybody knows, medicine that applies to adults does not apply to children, and many patients and many parents, they try to do what happened to their disease and apply it to their children. Before we start with this field that you're expert in, tell us about your training. Where did you train?
I trained in the UK, in Newcastle upon Tyne, doing my medical school. I finished there in 1999, and I got 1 year of training there as a house officer there in the Freeman Hospital. I came back to Kuwait. I worked for a couple of years in the pediatric department in Mubarak Hospital, and then I went on a scholarship again to Canada, in Hamilton, to continue my training in pediatrics and then allergy and immunology, which includes asthma as well, among other things. But then I spent maybe about a year and a half doing more asthma research into children and into adults as well.
Now, tell us about the field of immunology and allergy. It's a big field, and unfortunately, many things they say you have allergy. This is a common thing, from sometimes doctors and from patients. When they don't know what's going on with the patient, they tell him you have allergy. So tell us about this interesting field.
It's very common to confuse what allergy means, because as you say, it's a very common word to use. The area of allergy and immunology in itself is a relatively new area. It used to be in the past where the general pediatrician would see the allergy, and the same for the general medicine person. For adults, they would see allergies, and for immunology it was mixed. Hematologists would see immunology, and other doctors and other specialties. Over the last maybe about 30 years or so, it's become a training specialized program. The word allergy, as you say, is very common, but when we talk about allergy, we talk about allergy that's at risk for life, and allergy that is not at risk for life. And they are very different things. Allergy, which is affecting life, can cause what we call anaphylaxis, and this is a reaction where you stop breathing, you have swelling, and it's a very serious reaction that you need to see hospital physicians for that and get some treatment and investigation. As well, allergy includes many areas, so you can have environment allergies to animal dander or to pollens, depending on season, or to dust or fungus. Or you can have allergy to food that you eat, proteins or foods of different types. And this is more common in children than in adults, although it can be very common in adults as well. We talk about maybe about 5% of the population having some form of allergy related to food. And again, allergy affecting the lungs, breathing, or the nose, the sinuses, or the skin, or the GI tract as well. This is part of allergy, where they present with different ways. They can present with symptoms of sneezing and cough, where it's an upper problem, or they can present with swelling and rash, when it's a problem with certain foods or contacts, or they can present with vomiting and diarrhea when it's a food allergy. So it's quite a common thing.
Now, why do people get allergy? Why the body does not allow these things to happen? And how food become an allergen, or what is the really happening inside the body itself?
This is an excellent question, but the question that we don't have a clear answer for, unfortunately, until now. There's many theories about why we develop allergies. As you said, in the old times we used to eat things all the time, and nobody knew commonly about problems with allergy. An allergic reaction is a reaction where you develop an antibody against a certain protein. This protein could be food or could be environment. For example, if you talk about milk protein, right? Why do some children develop this antibody against this protein and others do? It's not very clear. One of the reasons is what we call a hygiene hypothesis, which you may have heard about. It's the idea that we live in a too clean environment, and this too clean environment from sanitation point of view is artificial as well. because we have a lot of milk products which are artificial.
Yeah.
We have a lot of foods which are manufactured artificially and processed artificially as well. Even the milk that we have, we give to children at younger age now, while actually it was made for, it's a cow milk. It's not made for infant babies and for humans. So we give it at younger age now because of work environment. People have to go back to work too fast. They can't breastfeed for other medical reasons. And we haven't been doing breastfeeding as common as we used to before. So that's part of the reason. And the other reason they suspect the cause of this is the fact that we use multiple medications and antibiotics.
Yeah.
Actually, many studies have been shown that if you use, say, about 6 antibiotic courses in the first year of life, you're at higher risk of developing asthma when you grow up. So in some ways, we are changing our immune system.
What do you mean by courses? That means 6 times?
6 times. 6 times.
During
the first year of life. Yeah. So
and it's very common to get these antibiotics, and sometimes the parents decide to give antibiotics.
Unfortunately, people expect antibiotics, but it's not based on full understanding of why they need it.
Yeah.
As you know, the antibiotic is made for a certain infection. It's usually a bacterial infection.
Yeah.
And in the first year or 2 years of life, 70% of those infections are actually viruses, which are not bacteria. They often don't need antibiotic, and even if you give antibiotic, they actually don't respond to antibiotic.
Yeah.
But they tend to take their course of time. So for example, like if you have flu, you're down with fever of 40 for 5 days, you're tired, you're very sick, you have not feeling well, and you're sleeping. But then it takes 4 or 5 days of the fever, then it goes away.
Yeah.
And you don't do really anything about it except take some fluids and rest a little bit. And the same thing is in children. If people can understand that most of the times it's a viral infection where the antibiotic is not as useful, they'll be more convinced about not using it as well.
But I also think doctors have to be blamed, because many doctors, they also jump to antibiotics very quickly.
It's true, because I think there's a barrier of understanding.
Yeah.
You need to explain to the parents, and sometimes us doctors don't have enough time in a busy clinic and practice in the emergency department to explain too many times. So they say to the physician, to the father or the mother, it's better not to give antibiotic, and they say, why? We should give an antibiotic. So they actually push for an antibiotic, and the doctor becomes, okay, so there's no harm in giving the antibiotic probably, but really long term there is harm. You get used to the antibiotic, then it becomes less useful, and as well you may increase the risk of allergy and affect your tendency or risk of developing more allergies as you grow up as well.
Yeah. Now, you mentioned about allergies and the relationship to immunology, and you said antibodies. So these antibodies is, some materials inside the body that attacks this foreign protein that comes through our life. And as I said, comes from the food, comes from the skin, comes from everywhere in the environment. Now, there is a question about the immunity itself. When we talk about immunity, usually parents get frightened, and they say, if my beloved child is immune deficient, or his immunity have a problem, and sometimes the immunity is working too much. So what's the problem with this immunity, and why that does happen? I know there are lots of questions about immunity, but the answers sometimes become difficult.
I'll try to make it as simple as I can. It is a very big field, as you say. Immunity is divided into 2 major components, maybe. One component is where you have confused immunity, and now in the case of allergy, or in case of autoimmune disease, sometimes in diabetes, thyroid disease, and other things, what you have is a confused immunity, where the antibody attacks the body and causes a reaction, or attacks the protein, which is normal protein, like milk, and causes an allergic reaction, or attacks dust and causes the same reaction. In immune deficiency, it's the opposite. It's where you have actually either an ineffective antibody, or you have no antibody. In that case, you don't really have a reaction to the infection where you should have. So you get a virus coming in, and your immune system does not attack the virus. So it's more going to sleep, if you like, as opposed to hyperactive. And immunity is not only antibodies, as you know. It's like one component is the antibody, but it's like similar to describing an army, if you like. You have things which fly, you have things which crawl, you have things which dive, and you have things which just protect in general. You have the first line of defense, then you have the second line of defense, and then you have a third line of defense. And you have a general at the top which is usually lymphocytes, which control the immune reaction. So it can be defects of any part of the immunity, first, second, third, or fourth line. It can be with the people who are not as specialized against certain infections. Which just, if you have an infection, they just come and start to attack the infection, but they are not strong enough. They're not specialized forces, if you like. And then they tell the specialized forces, because they've seen that infection before, to come back and come and attack it, and in that way they are stronger and faster. So usually the second time you get the same infection, you are much better dealing with it, and you get a better response and get better immunity.
Now, as you said, this is a big field, and probably it involves too many diseases in particular, you know. But what I want you tonight to explain to our viewers is that when my child having what kind of red flag that comes to the mom to think about immunological problem. Just simple, you know, because many children get infections, and this is common. Sometimes the child gets infection 3-4 times, and most of the doctors, they say this is, child they will get. But what is the red flags that the mom can remember when that happens? That will raise the flag to look into a serious problem. This is really a very important question again, and I have the same question asked by physicians as well, because it's a very common question. Now, we have to remember that when the child is born, he's protected for the first almost 6 months of life, almost 4 to 6 months, by antibodies through the placenta, through the mother. So if the child is born, that means immunity from his mom. From his mom. So at 9 months when he's born, he gets a lot of the antibodies transferred, which have a lot of immunity to protect the child in the first year, the first 6 months of life, as well as with breastfeeding. You get a lot of immunity components there. The infections and the worry you have is when a child has unusual infections, and they are with other things with it. So for example, will be an infection that you don't commonly see. I'm not talking about the simple cold. I'm not talking about the simple sneezing, coughing, upper tract infection. I'm talking about deep infections. For example, you develop an abscess. So an abscess is where you get a swelling. It could be under the skin, it could be in the armpit, it could be anywhere else in the body, it could be inside the body or inside the bones. And these abscesses are a collection of infection where you cannot get rid of. This is a worrying sign when you have such a thing, especially if it gets repeated. Maybe a once event is not a big deal, but if you have repetition, that's another important mark of it. If you have problems such as recurrent admissions to hospital, if you need to go to hospital too many times and be admitted and get antibiotics through the veins for a long period of time, especially if you talk about 2 weeks or 4 weeks, then you have to worry about the immunity of the child. Or if you develop complications where you don't really expect them. For example, it's not uncommon for a child to get a chest infection, but if a child develops damage to the lungs following a chest infection, this is a worrying sign as well. Children with what we call a primary immune deficiency, which means they are born with the immune system being defective, tend to be very sick, especially after 4 or 6 months of age. They tend not to grow, they tend to have a lot of problems with infections, and then tend to not look normal like other children. If you ask the grandmother or the mother of the house who has other children, she'll tell you simply, this child is different, he's not growing. But anybody with this chronic problem, does he really look different? Does he have to look different? Because sometimes he looks like a normal child. Look, the face may look different. I'm talking looking different. Not in this particular case. I mean, in general, if someone have recurrent abscesses, or does he have to be sick when he have, When they get admitted to hospital, there are two things, right? A child, by nature, is not an adult. As you said at the beginning, they are not really big adults. They are small children. So their immune system is not really well developed yet. You don't get to a normal host immunity, not a normal child immunity, until you're about 10 years of age. So from the time you're born to the time you're 10 years of age, your immunity is not really a normal immunity in the sense it's like adult. It's a learning process where the immune system gets exposed to infection and gets training to develop more immunity and gets better with immunizations and with infections. Now, the child may look normal from the face point of view, but they will not be growing very well if they have a very bad immune problem. Many children, as you said, you're right, they don't have a big immune problem, so they look normal, they grow normal, and they have this infection which they don't get rid of too often. So they may look totally normal, but that will be the unusual type of immune deficiency, where it's one arm or one part of the immune system is affected, but the other components are working very well. So they're not really as sick.
But children who have an immune deficiency which is bad enough, or immune problem, and they're born with it, they tend to be very sick, they tend to not to grow, and it becomes obvious in the first year of life usually.
Yeah. So any of these that will raise a red flag. We were mentioning about the children who are born with immune deficiency primary, and I interrupted you. Sure. So you wanted to say more about these children, the sick children.
Sure. These children have more obvious signs because they are very sick. It's usually, when I tell you they come as primary, it means it's inherited. So they have the genes from the parents that cause them to have a defective immune system or not have an immune system at all. And usually it happens within marriages, where we say within family marriages. So cousins, close cousins or distant cousins, usually have a higher risk of having this kind of problem. That's really what I wanted to mention.
Yeah. Now, this is the red flags that we have to think about. Okay. Now, before we get into diseases, immunization. There are many sometimes voices in the medical field and sometimes by people. They say immunization is the problem that causes immunity. Is that true?
To cause a lack of immunity?
Yeah, or that's really the reason why children get diseases, because of these immunizations.
I think it's not the correct presumption. Vaccines are specific for certain infections. So when you have the measles vaccine, protects you against measles. When you have the varicella vaccine, which is chickenpox, you have protection against chickenpox. When you have the diphtheria or tetanus vaccine, they protect you against the specific infection. No vaccine is actually 100%, but they're close to 100%. And they don't really affect your immunity in a negative way. As far as we understand, they are positive for your health, and they protect you from severe infections and from getting into complications with these infections to a degree, to 90% degree. If we talk about having more immunity, then you have more allergy. It's a theory, but it's not really valid, so we don't think about it. The benefit of vaccines is much more. We know of its benefit, we know of its side effects, if there is any, and we know it's very important to protect the population overall and against infections.
Yeah, I mean, immunization overall actually reduces diseases, but this is just to stress the importance of these immunization.
This is very important.
The timing of immunization is important, because some parents, they just get delays in the immunization, and sometimes they get confused because the system changes sometimes in terms of the time of immunization.
Sure. Right now in Kuwait, we have a very fixed and very organized immunization system. It's been very well developed over the years. It includes vaccinations at birth, then at 3 months, and then you have the BCG, which is for TB, and then you have the routine vaccination at 2, 4, and 6 months, which is for diphtheria, tetanus, pertussis, polio, and the pneumococcal vaccine for pneumococcal infections. Then you have at 1 year of age, which is for measles, mumps, and rubella infections, which is very important as well. And then you have later on, you can get optional vaccines, which are not provided in the Ministry of Health, but they're provided in the private sector. Rotavirus vaccine, for example, or varicella vaccine.
And these are for what?
Rotavirus is for rotavirus infection, which is usually a very common cause of gastroenteritis. So children below 1 year of age, when they come in with diarrhea and vomiting, this is gastroenteritis. One of the commonest causes is rotavirus. It causes many admissions to hospital over the years in the States, in Kuwait, and other countries in the world. And it's in the not so well-developed countries, it's a major cause of death because of dehydration. But in Kuwait, fortunately, alhamdulillah, we are very well developed in that area. We have very good service and healthcare, so we don't really suffer from this problem as common. But it's usually given as well as 2, 4, and 6 months, and it's a live vaccine that you give, and it protects you about 70 to 80% from rotavirus infection. And the varicella is chickenpox. So again, it protects you by about 80%.
But why are these not included in the regular vaccination? Is it important for people to get it, or?
I think it's a regulation thing. It's a policy by the Ministry of Health. Even in the States, it came on and off because of possible questions about complications. Right now, it's routine in the States, but not routine in Canada for all of them. It's becoming more routine. Even the human papilloma virus, which is a virus that causes warts and causes cervical cancer is becoming routine in the West in some areas, but we don't have it yet as routine. I think it needs some time for people to study it further and decide whether they can incorporate it from a financial point of view and from a need point of view. But there are definitely useful vaccines. I could mention this as a small point as well. Children who have immunity problems do not really respond very well to live vaccines. And it's actually, we don't advise them to take live vaccines. Because if you don't have normal immunity, if you get a live vaccine, you may get the actual infection. Because it's a weakened virus. But then if you don't have proper immunity to act against the virus, you may develop the actual disease. So you give varicella vaccine and you develop chickenpox. Instead of protecting you, you get the infection. The same with BCG as well. So this is one of the signs as well, one of the red flags that you get with those children with inherited immune deficiencies, not the usual ones, where you get complications following certain vaccines.
Yeah, so that's also, that's the job of the doctor to think about the patient before giving the vaccine itself, live or not, or dead part of the vaccine. Now, let's go back to your clinic in the daily practice. I know your practice is going to be different between Kuwait and Canada. How did you find the terms of kind of diseases you see in your clinic?
Well, surprisingly, in general, it's very, very similar.
Is it?
We get about the same percentage of food allergies, although slightly different. For example, in Canada or the States, you get a lot of peanut allergy.
Yeah.
Sabal.
Yes.
In Kuwait, it's not as common as far as we know, but it's there. We have more sesame allergy. We get a lot of cow milk allergy as well. Regarding the environment allergies, we go through the same peaks that we get in the West. So we have seasonal variation. So we talk about March, April, May, where you get the pollen for grass and weeds and other pollens. And you get a bad season. And then you get September, the ragweed season, and other fungi as well, and infections, causing allergies, environmental allergies. I see about the same in the Isaac study, which is the international study for asthma done by other doctors in Kuwait, Dr. Musa and other people. They have shown that the amount of disease with asthma and allergy in general is similar to the West. It's about 15 to 20%. So we find a lot of similarities, surprisingly. Maybe a little bit different in some areas of foods, but I find the major difference is really education. And this is one of the parts, the reasons your program is very important, because people don't have proper education here like they have in the West. People they have more access, they have better resources in English. For us, there are not many resources here for Arabic, for example, language, and they got a lot of education about allergies in general. So I think that's a major difference, really.
Yeah. Well, let's talk about food allergies. You mentioned, the milk and the sesame, compared to peanut allergy, which is very common in North America. What is the most common one you deal with? And tell us about it.
Sure. The commonest 5 allergies in the world, and it's the same in Kuwait almost, is cow milk protein, wheat, القمح, soy, which usually in soy products, and then you talk about peanuts, tree nuts like cashew, pistachio, and that kind of thing, and then you talk about as well. These are the common ones, but then you get fish and shrimp and all that when you get older. But usually these are the commons, and now sesame is becoming a very common one now as well. Sesame is becoming a very common one as well. But you can have allergy to any food, really. Any food protein can cause a reaction. The way they present is very different. It could be sneezing, it could be swelling, it could be shortness of breath. They get swelling in their throat and they cannot breathe. They could get a more bad reaction. They can get vomiting, they get rashes, they get diarrhea. But the most important thing, the most severe reaction is what we call anaphylaxis. And in that case, it's a very life-threatening reaction where the blood pressure drops and the child's at risk of losing their lives. And that still happens even in the West and in other countries. It's about like less than 0.5%. It's very.
But this happens suddenly. I mean,
it happens
for
suddenly.
the first time probably. They don't know if the child.
Or by accident. Or by accident. But nobody will give you something that you're allergic to by like intentionally. But by accident, because food is very difficult to control. And when you go to a restaurant, if you don't practice vigilance, if you don't ask specifically, what do you have in this food, you may miss a component. For example, if you go to take a soup and they have peanut in the soup, but you didn't ask about the peanut, you might get a reaction. In children as well, it's extra hard for the families because it's very difficult to control a child at a young age or what they eat.
Yeah.
They go to school, children share with food, they go to their grandmother's house, and they like to give them chocolates and sweets with a lot of milk and a lot of peanuts and a lot of tree nuts and a lot of other things. And people are not really aware of the possible problem. So the mothers or the fathers, mostly the mothers, panic sometimes. They say, doctor, what can we do? I don't know what to do. Like, you know, how can I hold my child all the time, make sure they don't eat that particular food? They do a good job because they look into things, they work like a detective. They go into the supermarket, look at the boxes and read, what does it have inside? Exactly, and make sure they don't have the food that the child is allergic to.
Yeah.
We provide what we call an EpiPen, which is an emergency pen, to be used in cases where you have anaphylaxis.
Yeah, we'll defer this, but to the treatment. But let's talk about the diagnosis of this issue, because you know, sometimes from experience of the parents, they say, okay, my child took this food and now he have you know, redness in his face. That means he's allergic to. And sometimes he's not allergic to. So you as a doctor, how do you make sure that you know, this patient really have an allergy to this stuff? Because food contains many proteins.
That's true, that's true. At most, we have many tools to test for allergy, but really what's most important, it's what the parents tell you. If the father or the mother or the grandmother comes and tells me, I have this particular food to my child, and within immediately or within an hour or a certain short period of time, they develop this bad reaction, which is bad rash, shortness of breath, vomiting, or any other problem. This is a very clear indication of allergy. Now, in some areas it becomes difficult to tell, where they're not really sure, or they have multiple things of allergy. In that case, we have a tool that we use, a skin test or skin prick test tool. It's basically we use the proteins and we apply them to the skin, usually on the forearm of the hand. And we scratch the skin with a small pricker. And we wait for...
Is that painful?
It's not painful. It's not blood taking. It's a bit uncomfortable. Because you get like a mosquito bite, you know, coming on your arm, and you feel like it's a bit itchy and a bit uncomfortable. It doesn't go deep. It doesn't take blood. All it does is just scratch the surface. But it's a small needle or a small plastic needle. So it does become a little uncomfortable for the child. And then after 10 or 15 minutes, I look at the arm and I measure the size of the wheal, which is the swelling, and we can decide based on that whether they have a certain allergy to that food. This is a very good test. It's fast and it's very specific and sensitive, meaning if you get a result showing you no reaction, it's usually reasonably good to tell you there's no allergy. If it's positive, which means the reaction, it's reasonably good to tell you there's an allergy there, but it's not 100%. We talk between 60 to 80%, so it's not 100%. What they tell you and what you ask about, so basically we call it a clinical diagnosis. What they describe is more specific to the diagnosis. Then there's blood test as well, which is again for the antibodies you have in the body for the certain protein of food. But again, it's about 60 to 70% specific. We depend on that and the chat we have in clinic. At times, we are forced to do a challenge. And basically, we ask them to bring the child into the hospital. We observe them in hospital. We give them a small amount of the protein. And then if they're fine, we give the protein again after 15 minutes. If they're fine, we give it after another 15 minutes. So basically, we observe for a reaction.
Yeah, you like, you know, transferring real life, you know, experience in the hospital where the patient will be under.
And that's really the optimal test. The optimal test of whether you have an allergy is whether you can eat it. To food in particular, right? So if you're able to eat it in a portion that's normal for your age and size, then probably you don't have an allergy. Yeah.
We'll continue with the allergy with our guest after we go to our weekly break with this report.
Outline. I turned left and my knee hit twice to the right.
Did you hear any sound coming out of the knee?
I didn't hear any sound, but I felt 2 hits to the right.
Two clicks?
Yeah.
2 clicks. And did it swell up straight away or after a while?
I'm not sure.
Did you feel any pain around it?
Yeah.
Was severe one?
Yes.
Where about in the knee?
Right here. And I couldn't straighten.
And how long did you have it?
It's been 2 weeks.
2 weeks. And it is like this, you can't put it straight like this one.
No.
Did you have previous injury?
No.
No, no. And what's the problem now?
But
2
now,
weeks is gone.
Yeah.
So what's the problem now?
I'm not sure.
Now it is hurting you? Can't you
It's not
straighten it?
hurting.
Does
I
it give
can-
way?
I can straighten it just a bit.
Yeah, and it doesn't give way in you when you walk? It doesn't feel
No.
stable?
Sometimes.
Sometimes.
Sometimes, yes.
Okay, then lie down and you'll have it. This flexible, you cannot push it down. Push down. You cannot push it down to make it like this one. And also there is a swelling around his knee. The good one will examine it first. And bend your knee, bend, even fully. Put it straight, bend this one, bend. You cannot bend it fully, put it straight. You cannot straighten it fully as well. Put it straight. Can you straighten this? This as far as it goes, and he can flex it back again or bend it back again. Also, there is a swelling here, which still have effusion in his knee, and this is a fluid inside the knee. If there is no fluid, it is normal. Then we examine this one. Bend your knee, bend this one. Bend the other one. Bend as far as you can. Okay, keep them together like this. Relax, relax, relax. This is normal. Relax this one. This is come up forward and go backward. So this is a sign of the anterior cruciate ligament rupture. Put knee straight. Put this one straight. And push on the medial side in this one and this outer side. So the medial ligament is stable, is intact, and the lateral ligament is intact. Relax again, relax, relax. This to test also the anterior cruciate, and you can see the knee goes up and down. So bend your knee. So he had anterior cruciate because of this test we call it Lachman test, and if we feel the meniscus here, the element, huh? There is pain. Any pain here? Any pain here? Yes? Yes. And he had a pain here. This is their medial meniscus and their anterior cruciate. So, but his knee is locked. This is not a good sign. So we'll give him about 2 weeks, 3 weeks physiotherapy, because it is advised not to do reconstruct the cruciate not before 3 weeks. So now he's about 2 weeks, so next week, if he's not put it straight, he must look by arthroscope, suture the torn meniscus, or take the torn part out if there's no blood supply in it. Then we reconstruct the anterior cruciate. We take a muscle from here by arthroscope and put it in replacement of the anterior cruciate. Thank you.
Welcome back. Tonight we have in-house Dr. Ahmad AlKhabaz, who is a consultant, pediatrician, and also specialist in allergy, immunology, and have a special, specialty in bronchial asthma in Mubarak Al-Kabir Hospital. Dr. Ahmad, we stopped at the food allergies and how to test them, and there are really ways to really get to test them. Now the question comes, you said there are some maybe 20 to 30% of patients that probably the test will not diagnose them,
Right.
and you rely on the history and chatting with the parents. But what is the really serious symptom that the parent or you consider is allergy? Because it runs from itching to redness to breathing problem, as you said.
Sure.
But sometimes they said, my child just itched after he took certain things. So what is the importance of these symptoms?
Right. The symptoms, as you say, are very wide. It could be anything. We worry about anaphylaxis, and I mention this again because really it's the most severe reaction. Anaphylaxis is easy to see because it's the kind of reaction that you have to go to hospital with.
Yeah.
Children usually will have a lot of swelling, their lips, their eyes. They have difficulty with breathing, they get wheezing, and they get swelling of other parts of their bodies. Their blood pressure will drop, and they are at risk of losing their lives. So it's usually a very bad reaction, and they come to emergency usually epinephrine and steroids and antihistamines. If you don't talk about anaphylaxis, then you talk about a very wide symptom description. It's usually not one symptom that gives it away. It's usually more than one thing together. For example, the child would have a rash, but then they would have some other problem. They would have vomiting with it. So if it's just one part of the body being affected, although it can be an allergy, it tends to be a very mild one, a very simple one, usually. Saying this does not mean you cannot develop a bad allergic reaction just from developing just simply a skin problem. You can have initially...
So that's an indicator.
It's an indicator, but it does not really gives you the full idea about whether they're going to get worse or not. Many children who get worse start only with a skin problem. So you have to be knowing your child. As you mentioned in the beginning, like, you know your body, you know your doctor, and you know what you need to do. So you need to know your child as well. If your child is at a younger age, they cannot really describe their problem. And this is what we look for. This is a major difference between you and the small child. You can tell me, doctor, I have an itch in my throat, which is usually the first sign of having a reaction to any allergy. But a younger child at 6 months of age, they only cry, so they don't really tell you, and they cry all the time. They don't know whether they're crying because of allergy or because of something else. So I'm not saying that crying means allergy, but I'm just saying that the child cannot really tell you what they have. So we look for the obvious signs, and the obvious signs are vomiting, not tolerating any food, and it happens every time you get the same food. That's usually a very common problem. You get a rash that is usually itchy, like a hive, and it's big. And then this child is having difficulty with feeding with other things because they're so worried about his food. So these are usually the common things that you see with those children. In some children who have very bad wheezing and very bad chest problems, I test them because it could be part of the food allergy. But then what we call a chronological order, which means that you take the food, you get the reaction. It's not common to get a food now and get a reaction within about 12 hours or after 24 hours. This is not usually a common allergy. The allergy would usually happen immediately. So within minutes, within the few hours for sure, within the first maybe 2 to 4 hours. If you go to the allergy department in the United States, they will tell you if it happens after 4 years, 4 years is too long. After 4 hours, 4 hours of ingesting the food, it's probably not an antibody-mediated allergy, which means it's not an allergy that you should worry about too much. Although in eczema, for example, which is skin allergy, the type of allergy is different, and you can develop worse skin after 3 days or 4 days. So these are the common things. The other thing is, maybe I'd like to mention, is the difference between an allergy and an intolerance. And it's a difference that we look for as doctors, but people don't recognize. When I talk about allergy, I talk about an antibody that acts against a protein that the child eats or the person eats.
Immunity is just
the immunity is overacting, and then you develop an inflammation, which is swelling and a reaction. Okay. You can have other types of allergy which are not really antibody mediated. So they don't have an immune component, but they have similar problems. So they can get itchiness, or they can get vomiting, or they can get diarrhea. But it's not really food allergy. It's intolerance. An example of that is lactose intolerance. So lactose intolerance is basically you don't have the lactase enzyme, you cannot break the sugar lactose in milk. So when you take the milk with lactose in it, you develop diarrhea, bloatness, and you get some vomiting in some children. So this is the same problem. You get the vomiting, you get diarrhea.
Same as G6PD deficiency.
G6PD deficiency is it's a reaction, but it
reaction.
doesn't. So, but you break down.
It's not an immunology.
It's not an immune problem particularly, but and it doesn't cause symptoms like allergy. You get breakdown of your blood cells and G6PD, and you get colored urine, and you get anemia. But in food intolerance, you get problems which are the same as allergy. And the same thing with many foods. You know, sometimes people say, don't give bananas, don't give kiwi, don't give orange juice, don't give other foods because they cause allergy. These foods, citrus foods in general, and as well as some other foods, caffeine, chocolate, tomatoes, they are naturally histamine-producing foods, which means if I take too much tomatoes, I'll develop an itch. It's not immune-mediated, it's not allergic. It's just you get an overdose of histamine. So this is what we get. The difficulty is this, that people come in, or children come in, and they get itchiness and problems of allergy, but what they are having may not be immune allergy, which we worry about. It could be just a normal reaction because of the chemical concentration of the food that they eat, causing histamine release.
Yeah.
And in that case, it's really nothing to worry about. So the skin test would not be negative, the blood test would be negative. When we talk about things, the symptoms will not be very strong, and all you need to do is just take an antihistamine.
Yeah.
As opposed to when you have a true allergy, antihistamine is not the right choice alone, because you may get into malnutrition if you don't take enough milk, you get lack of calcium, you get rickets and problem with your bone development, with your teeth development, because you're avoiding milk. So we tend to give them a specialized formula for milk allergy, which is broken down amino acids, broken down milk protein, so you don't develop a reaction. But at the same time, you get all the nutrients you need, the calcium, the iron, the calories, the fat, to grow properly.
Yeah.
So in allergy, it's very important to make sure you have a diagnosis, to tell you what you need to do, make sure your proper nutrition and proper growing, especially in the critical period of children where they need to get all the nutrients to grow at that time.
Let's move on to drug allergy.
Okay.
We still have around 5 or 6 minutes. So,
Sure.
What about drug allergy? Is it different?
It's actually very different. Now, allergies goes in individuals, and if you have one type of allergy, you're at risk of developing the second type of allergy. For example, if you have an allergy to one food, your risk of developing allergy to another food is higher. Even though most food allergies at young age you outgrow when you're older, certain allergies do not outgrow. For example, like peanuts, tree nuts, and fish. But I meant to say this because children who have a lot of allergy in general, whether that's a skin allergy like eczema, chest allergy like asthma, food allergy like milk, are at high risk in general of developing other allergies, including drug allergies as well. And once you get one drug allergy, you're at high risk of developing allergy to other drugs. The difference with drug allergy is that really we don't have the tools to test for it properly. The protein that we eat is the same protein we could test for on the skin or on the blood. But with antibiotics or medicines, they get broken down in the body, and the allergic reaction happens actually to the end products of those drugs. So it's not actual drug itself that causes a reaction. It gets broken down, say for example, to 8 or 12 components. One or more of those components cause a reaction. So we can't really test for it because those components are not stable on the skin or in the blood. They just develop after you ingest them. They tend to have late reactions as well, unlike food allergies. They could happen after 3 days, after 1 week, or sometimes after 20 days. So they are very different than food allergies. Thankfully, alhamdulillah, we have a choice of other different types of antibiotics. And sometimes in hospital we do what we call desensitization, which is basically if you need a certain antibiotic and there's no other choice, we give you a protocol in hospital where we give it slowly over a few hours, and we make you get used to it so you don't develop a reaction to it. But this is the only option we have in very bad cases where we have really bad infection.
But in these cases, because antibiotics are very commonly used in other drugs, do you advise parents to put like labels or bracelets or stuff like that?
Yes, absolutely. Anyone with a proven allergy, whether that's food or drugs, where you develop especially a bad reaction, and I guess you do the same with diabetes. In children as well, we do that. We label them, we give them a label, tell them that you're diabetic or have a certain problem. And this is important for them to know and for people who work with them to know. So for example, if the child is found unconscious, which can happen in cases of severe allergy, they would know they have a certain allergy. They could give them treatment faster. So we normally advise the parents, we educate them about how to use the treatments, what to do with food. We advise them to tell the close family and other people in the family. We advise them to talk to the schools as well, which is really a big problem, because school is where you spend half of your life, and we have little education in schools about the allergies, which is very important. We need to teach the nurses how to use treatments and what to do there as well. But at least, as you said, the minimum is to label the child and tell everyone close in the family and in school about the allergies and what to do if they develop a reaction.
Okay. What about, you mentioned earlier, the third type of allergy, which is environment allergy.
Right.
Now, we talked about food and drugs. So what is environment allergy?
Environment allergy is the same reaction you get with food, except you develop that to something in your environment. usually things which you breathe in, you inhale. So what you inhale is, again, things which cause allergy and things which are not immune mediated, so not an antibody related, but they cause problems similar to allergy. For example, cigarette smoke. Cigarette smoke causes inflammation in the airways, in the nose, in the sinuses, but it's not immune mediated usually. But it makes asthma worse. But the other part, for example, if you have pollen, so grass pollen, ragweed pollen, fungus like aspergillus in the environment, these pollens, when they come inside the body, you develop an antibody against them. But this antibody is directed towards your tissues or your lungs, for example, or your sinuses. Again, with inflammation, what you get is swelling. And with swelling, you get all the problems. So you develop cough, you get tight chests, because swelling makes the airways tighter and smaller. You don't breathe very well. You get phlegm as well. The common things you have are either at home or outside the house. So at home, you have the common things. The dust mite and fungus, and you have the plants and the perfumes. And outside, you have the environment.
And do you have the same protocol to test for these?
We cannot test for things which don't develop an antibody. So we test for the fungus, we test for dust mite, we test for the cat and other pets' dander, because they are proteins. But we cannot test for things like smoke.
Dr. Ahmed, thank you for joining us tonight. You gave us lots of information, and I think we still have to bring you back and join, to get into more details of other diseases of your specialty.
My pleasure. Thank you for the opportunity.
Thank you. Dear viewers, check our numbers.